two challenges with their connection. That we have actually cleared to some extent. I am still using the opportunity to connect. That's not in our HEDA Resource Center. This is to welcome all our panelists and the participants to this very rare occasion of having to bring our anti-corruption situation room, which has been before now on a physical note and across Nigeria to deal with issues of accountability, transparency, good governance, and social justice, using the platform to bring together different stakeholders and resource persons to be part of the process. Today, we're looking at the issue of social security, which has been brought to the fore by the challenge of our pandemic challenges that is facing not just Nigeria, but the world. And going forward with this, it is part of our concern and our other partners to see that we don't return to where we actually started with this, not just health challenge, but also economic, social, and even political challenges that has been occasioned with the COVID-19 emergence across the world. How have we fared as a country in Nigeria? Where are we going to get some of the needed resources to actually change the narrative and paradigm in terms of providing the necessary social and economic security for Nigerians in terms of the health sector? And that would be the focus for really today, is to see the kind of investment that is required within the health sector. What are the legal implications? What are also the possibilities? What are the challenges and what are the prospects to reverse the trend of Nigeria rated as one of the countries that for their health treatment and services at the expense of the ordinary citizens. And for us, we think that the challenge that is facing the world and the country in particular is an opportunity to have a reflection that can assist with the change of not only the narrative, but also our lifestyle, the investment of the country in the health sector. And we have an array of eminent panelists in the field of health, labor, social security, and legal as well, to look at these issues. And we have about 150 registered participants. As at this morning, we had 150 who are also joining to listen in and be part of the process. And I'm going to hand you over to the chair of the board of HEDA Resource Center, Professor Ayo Atsenuwa, who would be the moderator and facilitator of the anti-corruption situation room this afternoon. Prof, over to you, ma'am.
Okay, good afternoon, everybody. It gives me great pleasure to welcome you all to this 19th Anti-Corruption Situation Room Dialogue. And first, let me thank you all for coming as chair of HEDA Resource Center, and at the same time as the one who's been invited to moderate this particular dialogue. And I am hoping that it will be a very, very fruitful one indeed. I want to apologize on behalf of HEDA that we are starting definitely very late. This is some 20 minutes behind schedule. And we will give it our best to try to gain time so that we do not keep you on screen for for longer than is necessary. Thank you very much, Larry. And so without much ado,
Yes,
because as I said, we're already 20 minutes into our time, and we've got to be able to save that time so that we can respect the time of facilitators as well as other participants. So let me say a very big welcome to you all, and urge that we all seize this opportunity basically to chat, to contribute towards charting a new course when it comes to helping Nigeria to retrace and at least gain traction in the anti-corruption war. And war it is, it's not just a fight, it actually is a war. I want to thank our presenters who have accepted to join us today. I want to thank our, I think at this point in time, over 40 participants who have joined aside our facilitators. And I want to thank HEDA's partners for joining hands with us to do this today. Our theme for today is actually COVID-19 pandemic and the necessity of comprehensive social security in Nigeria, focusing on the health sector. COVID-19 has reshaped our world. COVID-19 is like the core of everything. That we're even able to have this meeting online is probably thanks to COVID-19. Not because we could not have done before, but because we hadn't stirred up sufficient willpower, you know, to migrate to taking advantage of the virtual space for holding dialogues such as this. But now that we have no choice, we've come full steam, and we seem to realize that this is such a great opportunity for us. And while we seize on it, I hope that we will not seize on it just to jaw, but actually to take some very tangible things out of here. Larry, in his introductory speech, did note that Nigeria has been assessed as at the lowest rung of the ladder when it comes to health indices. Indeed, the health status is so poor that the life expectancy is remarkably low relative to what you have in the other parts or in some parts of the world. And you would even find that those you'd expect to be comfortable as some of the people who are migrating out of Nigeria. And when they tell you one of the key factors why they are, aside from safety, one of the things they will tell you is that the social infrastructure is so inadequate to support life and guarantee security. So you'd find people saying, you know, you can't, even as a so-called emerging middle class member, you can't pick your bills. We've had programs, we've had interventions such as the NHIS that's designed to address. Part of why we're here is to assess how effective has it been? What more will need to be done in such a way that in the post-COVID, in this era of COVID, and in the post-COVID era, what's going to happen? Why do I say in this era of COVID? Because from all the things that we hear, COVID isn't about to disappear for some time to come. Some people expect us to have it around for another 2 years. And when we say have it around, we're going to have it around a lifetime, just like we have other viruses. But we're going to diseases caused by other viruses. But in terms of the emergency, and in terms, it's going to be around for us for much longer than we can, for much longer than we should imagine is just about a few months. It's likely to be about a year. So we still have a long haul, and before we actually get to a time we can describe as post-COVID. So without beginning to take the dialogue myself, or I would like to welcome our speakers. We have 6 speakers with us today. We have Professor Joy Ezeilo, who should be our first speaker, and she is the current Dean of the Faculty of Law, University of Nigeria, Nsukka, and Professor Joy Ezeilo wears many caps. She's done quite a number of things with her life. She is the Executive Director of WACO and one-time UN Special Rapporteur on Trafficking in Persons. And this is just to mention a few of the things that she has done. Also with us is Dr. Muiz Banire. Dr. Muiz Banire is a man of many parts. I knew him when he was an academic, but since he left academia, he has gone on to be an active player on the political scene. He was one-time Commissioner for Transport and Commissioner for Environment in Lagos State. I know him also to be a social activist, and he is the convener of the UKAid, which is the United Action for Democracy. Also with us today is Dr. Wale Okediran. Dr. Wale Okediran is a medical doctor by profession, but he's also a man of many parts. He has been a legislator in Nigeria, being a member of the House of Representatives for some time, and he's also an author. In fact, he's so distinguished as an author that he was one time president of the Association of Nigerian Authors, I think it is. But he is a commentator on health issues, and many of his plays many of his literature writings have been devoted to casting light on politics in Nigeria, amongst other things. Then we have my dear friend, Dr. Comrade John Odah. John Odah, I have known for a very long time as a labor activist, and a labor activist both in Nigeria and a Pan-African labor activist. He has represented Nigeria on the ILO a couple of times, and I am sure that his contributions will be pretty grounded and profound. We also have Mr. Aminu Magashi Garba, who is the coordinator of the Healthy Newborn Nigeria Network, Healthy Newborn Network, and he is also the an executive member of the African Health Budget Network. And I believe that it is in that capacity of health budgets that he has been invited and identified as a great resource to have join us this afternoon. And then we also have Dr. Gbenga Oduntan. Dr. Gbenga Oduntan is an academic. He is very renowned for his work in anti-corruption. And I dare say that like every other resource person that we have identified to lead our dialogue today, he would have a lot to tell us about how we can strategize. The objectives of this meeting are very clearly laid out, and they have been shared. I will not take too much of our time going over that, but I would just want to say that the way we will proceed is we have 6 speakers. Each of the 6 speakers had been advised that they would be speaking for like 15 minutes. But having lost the amount of time that we have, I want to appeal to our speakers to please give us 3 minutes of their time at the minimum 3 minutes, so we can save 18 minutes and we can use the 18 minutes to engage without having to overextend this particular Zoom session. And I hope that works well for all of us. In terms of still speaking to how we're going to approach the discussions this afternoon, we're going to try very, very hard not to spend a lot of time bemoaning and bewailing the issues. We know the problems. What we want to do is let our discussions, let our dialogue be very, very strategic, where our goal is to identify what opportunities exist, what strategies we can adopt, and our goal is to strengthen our individual capacities in whatever it is we're doing, whether we be academics or whether we be social activists or whatever it is to strengthen our individual capacities to do better whether directly in intervening within the community or in terms of advocacy, but at the same time to build a synergy so that we are able to help define, reshape the agenda. Reshape the agenda by defining policy, by defining policy and identifying strategies for building support to actually ensure that these strategies go beyond paper. This is critically important because we cannot afford to carry on the way that we have done. It is critically important because for the first time, I think government in Nigeria accepts that the health system in Nigeria is in a dilapidated state. The chair of the Presidential Task Force on COVID did admit before the House that, I think if I can paraphrase him, his words were like this: believe you me, I did not know that the health system in Nigeria was so bad. Now that they know, we must be there on the vanguard to ensure that we do not lose steam and we push forward. So on that note, I want to say welcome once again and begin to invite our speakers. I see that Professor Joy Ezeilo is with us. Professor Ezeilo is the first speaker. Professor Ezeilo? Can we see your face? Can you unmute and let's see your face?
I don't know about my face today because COVID, we've been doing several things, you know, so I'm practically, doing exercise and trying to keep fit. So I just came back from,
okay,
so
that's all right.
Yeah, so, but anyway, we can, thank you so much, Professor Ayo Atsenuwa, my sister, Prof, and the Dean of UNILAG, and also the chair of HEDA. My fellow panelists, HEDA and the organizers, I want to thank you for inviting me to speak on this very burning topic, especially at this time that we are living in a pandemic that the world has not seen in the last 100 years. And it's interesting when you think about this COVID-19 and how the world has come to a stop because of this COVID-19. If you just think back, even I recall, even as the UN Special Rapporteur on Human Trafficking, when I go on a mission and we look at what are kind of assistance and services that are available to traffic persons and to also other victims of transnational crimes, especially also as migrants when they are in countries other than their own. All the time issues of social security coming to fore, issues around access to health coming to fore. And they always, when I'm looking inward at the countries, you look at the budget they have for defense, the budget they have for health, and particularly in African countries, and then of course, even the world superpowers, they spend billions of dollars amassing the latest technology in terms of warfare, weapon, nuclear weapons, and all what you have, what have you. And we thought Cold War has ended, yet the expenditure in terms of defense, military defense and hardware is extraordinary. And it's just a tiny unseen virus that has, in fact, we're all battling. I'm positive that the world will defeat it. But like the moderator said, it might be with us for a long time to come. But think of it, unseen virus has brought the world to their knees, to a stop, humbled America, as people are dying in thousands in the United States, in all that countries of the world, including those who are doing nuclear race like Iran. It just kind of showed up everyone. Like you are non-starters. We have not focused attention on what matters, which is the health of the people. And it's also when you have health, when you have social security, when you have all the services, including social insurance and health insurance, then you can talk about wealthy nation. The world definitely in the post-COVID era is going to go into unprecedented economic recession. We're already seeing countries like Nigeria that is mono economy, that is largely dependent on petrodollars, what is already doing to our economy. So now, what are the issues? It has also, because I know that because of what is happening and because of the current pandemic, the world will now focus attention again and again and prioritize issues around health, social services, social security, social insurance, universal health coverage. Because if we think of our humanity, and if you think about basic right to life, what does it mean? Without life, without the human beings, without healthy human beings that will run the economy can never be healthy. And we can never thrive. And then we are mutually vulnerable. It exposed, this COVID-19 virus exposed the mutual vulnerability of the world. Whether you live in the north of the world or the south of the world, it doesn't matter. Our fates became intertwined. From Wuhan, they said the virus doesn't travel, it's a human being that travels, and we know, of course, migration is a marker of globalization. From Wuhan, it got to every part of the world. As at the last count, probably when they talk about 2 or so countries, it must be remotest island where they haven't seen the virus. It's the places that we struggle to see also on the map of the world. But look at how it has impacted on lives. Nobody would have predicted at the beginning of 2020 that our calendar will cease to matter anymore. Our travel itinerary will become meaningless. And that even as people are talking about gradually opening and partial lockdown and all of that, we still don't know where we are. Okay, so back to the legal basis for social security in Nigeria, which is the main issue. At times, I don't know, because when you look at it, you say, oh, really? Are we talking about this in Nigeria? Have we ever really focused on this? It's always every woman, every man unto yourself. You can, be responsible for your own health care, be responsible for your own social security, to any social services. You have to just fend for yourself because government give us so little. Our taxes, our collective taxes, has never worked for the people. Our commonwealth has never worked for the common good of Nigerians. Despite the provision in section 14.2 that says that social security, the security and welfare of the people shall be the primary purpose of government. And if that is so, you expect that you get to the hospital and you find state-of-the-art facilities. You expect that your right to life include right to adequate treatment and means of livelihood, and decent means of livelihood. And talking about COVID, of course, people say the greatest, one of the things, the measures, the preventive measures, apart from stay at home, the lockdowns, is wash your hand, use sanitizer. And there was a joke I saw on a WhatsApp yesterday. They say where you don't have the basic, and then you say people, you provide water for washing hands when people don't have water for drinking. So you see a little child go and put his mouth on the tap there, trying to drink the water meant for washing hands. Because it has thrown up issues around sanitation, water and sanitation, and importantly as a human right, and access to clean water and sanitation as a human right. You see, one of the things that I said, look, I've always we have so much to do even, but I said, I don't think we have enough people working in the area of open defecation who can say, look, how can a country have people so open? You go in Abuja, even in the center of Abuja, even right in the secretariat of Abuja, and then you see people doing open defecation. You go to the airport, including our international airport, it is an eyesore. So the legal basis for social security, it is a fundamental human right. And of course, people can argue whether the Chapter 2 of the Constitution of 1999 Constitution of the Federal Republic of Nigeria as amended is justiciable or not. But it is, of course, because we've gone beyond this to the extent that the African Charter on Human and People's Rights formed the second regime of human rights in Nigeria. and that is also legally binding. And Nigeria has transformed it into a domestic legislation. So starting from the Universal Declaration of Human Rights, it recognized the right to social services, social security, right to security even in the event of unemployment, sickness, disability, widowhood, old age, for the elderly, because we know how the COVID affects the elderly, or for people who lack means of livelihood because of circumstances beyond their control. It requires that they are provided for. And Article 25 of the UDHR, for example, said motherhood and childhood are entitled to special care and assistance. And why is that so? You can link it to CEDAW, Article 5 that said, because maternity should be seen as a social function. And we're battling with high maternal mortality and infant mortality. And I hope some of our policymakers will also know that we have had these issues about maternal mortality and morbidity with us, and one of the highest in the world. Because I don't think we can all feign ignorance that we don't know about our state of our healthcare facilities or our social services, or that we have near to zero. Yes, today may be better than yesterday, but we are still far, far, far away from where we're supposed to be. Article 9 of the International Covenant on Social and Cultural Rights, which Nigeria has ratified, provides right to highest attainable standard of health. And this includes treatment, prevention, and control of epidemic, endemic, occupational, and other diseases. And those other diseases were in the era of a pandemic. And we're talking about people having even not just sanitary condition, even as this is happening. I was just wondering how many places are being fumigated, being disinfected, public places. Nobody have passed my street. I don't know about you. And then the gutters, and you look at it in the public, everywhere is still, stench. So we're just like living in a different planet in terms of what are the government responsibilities and how the COVID response should be targeted at looking at issues of social security that matters to life, in Nigeria. I don't need to bother you with the economic indices or socioeconomic status of Nigerians. And the fact that we have young population, huge youth population, mostly out of school, mostly out of work, leading to them taking all kinds of risks, including irregular migration, getting involved in crimes, criminal activities, transnational crimes, being trafficked, and things. So
thank you.
For me, because we say, let us not bemoan, yes, but we have to lay the foundation. And then, foreground, my point here is that government has a responsibility. There is a responsibility of Nigerian government to protect, and of course to respect and to ensure that everyone have access to necessary social services or social security, including even social insurance. I know for the government establishment, that's why I said today is better than yesterday. They have, we now have in the public sector, universal health insurance, health insurance coverage that people are benefiting from. And for those who can't afford it, it's still very helpful for them, right? But what about the people in the informal sector? What about the aged? What about the person with disability, the widows, those who can't fend for themselves? There is no safety net for them. Section 17 of the Constitution of the Federal Republic of Nigeria, it talks about the state social order. And I mentioned every citizen shall have right to equality of right, obligations, and opportunity. But importantly, it talks about the health, safety, and welfare of all persons. Those in employment, that should be protected, safeguarded, and not engendered or abused. And the issue of adequate medical and healthcare facilities for all persons, and without discrimination. And prohibition from discrimination is protected by Section 42. It's a fundamental human right. And once you link that to this chapter 2, it becomes justiciable. There is a number of authority or jurisprudence, which I wouldn't go into, technicalities and, talking about case law and stuff like that. But we know there are, of course, few case laws that have come out, including the right of prisoners even to access healthcare facility. Does the fact that they are convicted and sentenced take away their right to health? Of course it doesn't. And there have been cases that came out, with regard to HIV/AIDS and right to treatment. What does right to life mean? If you diagnose somebody of COVID, doesn't the person have a right to be treated? Of course, it's a public health emergency now, and then I know that all of them are getting treatment free. But there has been issues of Nigerians returnees who have been quarantined by government and who have been asked to pay cost of quarantine, cost of feeding and everything. And I've had a lot of discussion, people have had discussions saying, then what are the legitimate expectations of people as Nigerian citizens? Is it that the government and you're a taxpayer, your tax cannot be used meaningfully for you or to benefit you, and in an era of public health pandemic like the COVID? So what do we do? I think the solutions we know now, but the big question, the big elephant in the room will be who will fund it? Where will the money come from? And I know that post-COVID, the IMF will come, the World Bank, the Bretton Woods Institution, and they can tell us, yeah, we can't afford this. Nigeria, you can't afford social security. Nigeria, you can't afford. For how long? And even sometimes it's not about the coverage. Some people are willing to pay more tax, but let them have the basic social security, social services, so that they don't think about if they fall sick, then they cannot afford the treatment that they need to stay alive. So where will that money come is the big question. What is the percentage of the health budget in Nigeria today vis-a-vis the defense? And the defense, of course, the government can try to justify it again because they can say, oh, we are fighting insurgency, we are fighting Boko Haram, and that has taken a big chunk of the money. And then it comes back to the main issue that HEDA deals with, corruption and cost of governance, and how corruption has also deprived people of what ordinarily should be their right and entitlement. So the corruption, what should be things that are intended for public good, in the end being used, the advantages people take because of their official duties and deprive others of their rights. That's also part of the corruption we've seen in this society, that embezzlement, diversion of this fund that will have benefited others, our commonwealth, does not allow us to develop in the right direction and to have a proper framework for social security. But we must begin somewhere. And of course, there is a lot already framework policies in place. If you look at the policies, they are already towing the right path, but implementation and effective implementation and issues around funding is a big question. Because even when you legislate, we know law is not a panacea, but when you legislate also, you think about the cost of that legislation. And I think when it comes to the cost and the implementation is where we have a challenge. So we must come up with a novel or innovative ways of financing in this area. But again, there are already existing. Let's take, for example, the TED fund, the education tax fund, health tax fund. People pay, corporations pay these taxes. How can you earmark some of this going into funding this? People already have pension. People have, their checkup of different things. How do we ensure transparency and accountability to make sure those things work? Even in the COVID era, there are government intervention, and I hope there will be one of the panelists who can speak to that because I won't cover that. The issue of both whether it's cash transfer of food for school meals and stuff like that are meant or an aspect of this, but in a very, very, will I say micro level, but still citizens are worried about the transparency of that, about the corruption, and perception is everything. Because if government don't publish what they pay or who benefits from what or whatever palliative, then it gives impression that we're not transparent and that something is going on behind the scene. And these are things where accountability comes in and where the civil society organization must continue to raise the accountability stake. So I think I will stop here and give others a chance. I know we've been asked to save some minutes. I hope I have saved some minutes. Thank you.
Madam Moderator, you are on mute. Prof, your mic is muted.
Maybe
Yes,
send
the
me a
host.
text. Okay, good.
Again, it's muted.
Okay, I'm unmuted now. I was muted by host, and so I could not unmute myself.
Hey.
Please be on alert because I was trying to unmute myself, but I couldn't. Okay, so thank you very much, Professor Ezeilo. Thank you for very interesting perspectives shared. The only thing is I can't resist telling you, no, you didn't save time at all, but we forgive because of the value of the perspectives and the thoughts that you shared. And it's really critical that you were able to help us go beyond, you know, the interesting thing about public health is that even though you're talking about the right to health, you're actually talking about things that all too often we would not think of when we're thinking of immediately about health. So you were able to draw attention to the issues of access to water, clean water, sanitation, the issues such as waste disposal, issues such as social security in event of unemployment and old age, and show us how COVID then reveals to us why it is important that social infrastructure must be strong and effectively in place. And of course, you raised the question of who will fund it and how will it be funded, and why we need to begin to think ahead in this regard. And I'm hopeful that this dialogue and some other dialogues to follow will actually address the how do we fund, and then maybe do something like a working paper that can be presented to government. So thank you very much, Professor Ezeilo. Let me quickly invite Dr. Muiz Banire. Dr. Muiz Banire will be speaking to us on an assessment of Nigeria's health insurance schemes and policies, taking a brief look at the successes and the challenges that remain with us. And I implore participants to please include your questions in the chat so that we can get some of this out for later after the presenters are done. So Dr. Muiz Banire, please, you have, can you give 12 minutes if you can?
Thank you, Prof. But somehow along the line, I think there is a disconnect somewhere. I wasn't really restricted to the issue of health insurance.
Okay.
In the communication to me, I was just had to come and be a general participant. But notwithstanding, I think I will start from that premise that you have indicated. For me, of course, it has been mentioned earlier that we have some measure of health insurance being promoted all over the country now, right from the national to the state. But the potency of them and the efficiency arising from it is what needs to be evaluated. And from my own perception, because I've had some interaction here and there and some few roundtable in the evaluation process, and we discovered that up to now, we cannot say beyond maybe at best 10% potency in terms of the coverage, in terms of delivery at the end of the day. And I think that is still a major challenge. So I was going to say, even initially before I was asked to address the question, that what we need to do is to actually promote that scheme beyond what it is now. As rightly pointed out by Prof earlier, that how many people can even afford this 4,000, 15,000 contribution, particularly from the informal sector. It's a major thing that somewhere along the line, the government might need somehow to come in and subsidize for some people, particularly those they now consider to be the poor and the vulnerable. And if we have the kind of funding they are using for palliative that are being contested all over the whole place now, I don't think that it will be difficult, particularly the way the Central Bank of Nigeria is even appropriating funds these days, not to be able to apportion something tangible and reasonable to cover this large track of people that are still excluded from the various scheme. I think that would be a solution to that one. But beyond that also, my view of the whole issue is that the HEDA for a long time now has been talking about the issue of corruption, and all of us seem to be carried away with this issue of corruption. I've always disagreed to a certain extent. For me, the major challenge we are having, particularly in view of all the issues that are ravaging us today, is not so much about corruption. There is the corruption element, but there is one aspect we haven't been addressing, and it's very, very much more debilitating for me in terms of what is happening to us as a country, and that is the area of incompetence. And I want to say, without fear of contradiction, that the price we are paying, and we've been paying, and which are continue to pay for incompetence, is much higher than that of corruption. I would rather prefer a corrupt person that is competent to administer me than somebody with integrity or that is corruption-free without competence. And this is the area we need to address as a matter of urgency. Otherwise, whatever discussion or engagement we're having, we are just joking. Because at the end of the day, you have a legislature or parliament where we have more than the comfortable majority of them not knowing which one is which. They don't know their right from left. How do they prioritize? What do they even understand about health issues? As far as they are concerned, once they have access to medical tourism, that's the end of the road. They don't care about what you are talking about, the prioritization and all those issues. But when you have the right set of people in position, both at the parliament, the legislative level, and at the executive level, then they can start understanding the issues you are raising. And I believe that that is one area that, by way of prognosis, that we must look at by advocating that the time is overripe for us now to start addressing these issues, that the right set of people must man institutions generally. If you do not have a right person manning any institution, that is why you find out that most of our institutions that have been unveiled now to be very weak, very, very weak. And that's part of the aftermath of this COVID-19 now, that we have now seen that most of these things are weak. They cannot actually sustain our challenges. So I believe that's point number one that I want us to look at. Secondly is the issue of this allocation, proper allocation of resources and prioritization. As rightly observed by the last speaker, you cannot have a healthy nation without healthy citizens. That is truth. And there can never be any growth because productivity will be impaired when your workers or your people have to regularly visit hospital or collapse regularly or under one form of payment or the other. The other country can grow. So prioritization of issues, but for you to do this, to be able to get the proper allocation of resources at the National Assembly, you need to engage these people to let them see. And you need to go in a very, very rudimentary manner because with due respect to most of them, the truth is that they don't easily appreciate or comprehend things. You need to actually go to the ABC of it for them to plug a nexus between productivity and the life of the citizen. Until you are able to do that, they might not be able to allocate adequate resources to deal with both the issue of the health facilities and also the health insurance for the generality of the people. That's the second aspect that I feel that we should look at. The third one again is that today, Prof raised the issue of funding. We all know if you have been looking at our budget, we are having almost 70%, if not in excess of, being recurrent. And this is as a result of the cost of governance, very, very unnecessary ones for that matter. We've had the proposal, I've forgotten now the name of the man that did the proposal on merger of parastatals and agencies. That report has been on, the white paper has been on since. Implementation is a challenge. Recently now they just told us, the Minister for Finance, that it will be implemented. And I tell you, the way they are even going again, certainly is already to assume a shape that it will never take off. And the cost associated with recurrent is too much. No country can grow in that kind of, with that kind of structure. We need to get them to reverse that trend. Look at the National Assembly. Look at the kind of money that goes into individual pockets of parliamentarians beyond even the amount they appropriate themselves for that constituency without any form of prioritization. This must be reversed in favor of the concrete, like something like health, as critical and fundamental as health. So for me, we need to actually, as a matter, bring this to their attention and establish the nexus between even their own existence and continuity and the people's health. Then again, Prof, is the area of infrastructure in earth. We need to address the area. I'm not even a fan of the government doing so at all. I'm not a fan of it. My experience in India is that CBN, as we have in Nigeria now, and other financial institutions must be able to promote investment in the earth infrastructure. Doctors need not have hospital. They only need to have a place to go and consult and diagnose and treat people. This is what is being done there. You find a particular place in India where you have a whole structure of about almost 20, 50 theaters. People go there, they just pay, they do the operation, they leave the case. That's all. This can be promoted actively by, for example, giving these promoters or the investors a single-digit interest rate. This will promote the establishment and investment in the social, because if you are waiting for government, we are going nowhere. As far as I'm concerned, we need the private sector to actually invest in it. And to invest in it, the government must now see as a facilitator and promoter through the private sector for the basic infrastructure. And I think that is equally one area that we need to discuss. Now, I've mentioned the issue of health insurance, that as far as the health insurance is concerned, there are so many other funds. We all witness or add, at least at the bare minimum, of the kind of scam going on there. There's so much money in that place. These are money ordinarily that should be used for the purpose of promoting those private sector investment, because they can be used, they can be given out even at single-digit interest rate level. And I think this is very vital for us to look into. Nobody is actually looking at the fund in possession of NHIS right now. Now, again, I want to say the issue of alternative medicine. We cannot pretend not to know that as of today, majority of Nigerians still patronize alternative medicine. Majority, I'm saying so with all sense of seriousness. And if this is correct, what then happens is that we must be seen actively now to start promoting and modifying, because we know the challenges there. People will say, they don't know how the measurement, we don't know the component and all those ones. We have institutions that can work on this. It's much cheaper than even the orthodox medicine. The health facility, much cheaper and affordable to majority of Nigeria, particularly those rural dwellers. And I think that we need to revisit and actively promote and modify this area in our collective interest, even for the purpose of the health insurance, because today an health insurer will tell you that, no, I'm not countenancing abolition. There's no way I will deal with you when it comes to that. I'm not going to pay and all this thing. We must work it. We must find a way of integrating it into our system. Again, we need to revisit our syllabus and also our work rules. Lifestyle, as far as I'm concerned, is 90% of our health. Our lifestyle mainly are the source of our various ailments. In our school syllabus or school curriculum, we need to devise a way of teaching us. Not until I became an adult that I knew how to sit, how to pick things on the floor correctly. And everybody taught me in school. And I was already breaking my back at that point. Nobody taught me. So these are the issue of lifestyle must be taken seriously and incorporated in our school curriculum, and even within the workplace environment, that there must be certain times that people must exercise it. You must compulsively go and exercise. These are some of the things that I believe also we must address if the health of our citizens must be guaranteed. And lastly, Prof, this might appear a bit radical. I've never been, again, a fan of all these social intervention schemes by the federal government. I've always believed that it's a complete waste of time. It's, for me, it's not achieving any desired goal. Just like the school feeding program that they are doing now, that there's, when even there is lockdown. No data, nobody has been able to give us. People have been asking for data for the people that palliative or the social intervention are going. They say we can't give. Under what rule? Under what law? Are you not giving us information of people collecting? Right now, how many do we have the data of the students? Do you know where they live? Some are even living schooling where their mom, their parents trades or work, where they are living elsewhere. Are you going to get them to come and collect this thing? Which center? And we want to discourage people to be out of the environment. We want to promote social distancing and physical distancing in the midst of us. It's a complete sham. For me, the money that is being used for social intervention and all these palliatives that are unaccountable should be rerouted to the provision of health infrastructure in the country as a matter of urgency. And lastly, Prof, I also believe that before we even get to social security scheme, let us address the question of basics. That one, with due respect to the promoters, is still a bit, to me, a mirage. Let's address the basic. Water, we just said the issue of water. How can you promote right to life without water? People don't have water to drink, and you are saying that they have a right to live. How can they live? So basic like water, education, let's promote it. Let them just even give us those ones before we get to the letter of social security scheme. And I think that's one for now. Although taken for granted in other jurisdictions, is still a luxury in our own environment. So these are my various thoughts, Madam Moderator. Thank you very much. I hope I've been able to save time.
Yes, you have done well. You've done fairly well. Thank you very much. Again, I say that I am unable to just abruptly stop our speakers, not because I'm not mindful of time, but on the virtual space it's a bit more difficult, and it can be a bit disruptive, but much more because of the quality of their contributions. Dr. Banire has taken this on with some very solid, actionable suggestions that can give direction in terms of next steps for us. And there are two areas where he has begged to radically depart. The first one that he says is that we should take beyond the corruption concern a look into the issue of incompetence. But then some people may answer and say, Dr. Banire, maybe the reason why you find our institutions populated with incompetent people is that that is a fallout of corruption and nepotism. When corruption and nepotism alters the recruitment or appointment process, you get the wrong people in, and also often the wrong people gather onto themselves also people of their ilk, largely because if they have too many competent persons, then their incompetence will stand out. But that's just an argument. So thank you very much. I believe that we have some very interesting ideas here. We will come back to them. And I see that some of our participants are also engaging with some of these thoughts already. So I will just quickly move on to the next speaker, who is Dr. Okediran. Dr. Okediran will also be speaking on, well, if he is ready to, or if he's not, whatever is ready to, because we find out that regardless of what is, people are really sharing profoundly. But the topic I have against his name is health insurance for the most vulnerable Nigerians, the role of the state social health insurance agencies. And I think that's a very good topic to come after Dr. Banire's last one. Dr. Banire did say that he does not believe in the social intervention schemes of government, largely because, and I don't think it's because it thinks that conceptually it is a bad idea, but he has seen that in the context of Nigeria, it hasn't worked. Because government's tradition, which we have not been able to unpack until now, is a failure of accountability. And so he's reluctant to embrace. And he also concluded with a statement that maybe if government focused on providing basic health infrastructure, and supporting this with public health education, then the need for government to intervene in the areas, the social insurance schemes that they are talking about right now may not be so compelling. But let's hear what Dr. Okediran has to say to us of his own, and in response to some of the issues that have been flagged earlier on, and particularly because he's been on the floor of the House, and he can tell us how these things work, particularly. Thank you very much, Doctor. You're very welcome. Good afternoon.
Thank you. Can you hear me now? Madam Moderator?
Yes, we can hear you.
Can you hear me? Right. It's a pleasure to be here. And I want to start by saying that I've been very strenuous on our psyche and finance and everything. I see it as an opportunity for us to be creative. For example, this meeting is taking place online, is part of what I can call to be the our response to the pandemic and so other things. Now to the issue of the National Health Insurance Scheme at the national and state level. I think a little background about the National Health Insurance Bill will give us an insight into some of the challenges we are facing. As many of us will know, the bill was passed by the last National Assembly, but for some reasons, it was not signed into law by the president. And because of that, well, maybe I should say one of the reasons was because there was a dispute between the presidency and the legislators on the position of on how the executive secretary of the association will be appointed. The lawmakers thought that even though the president will nominate the candidate, the fellow should still be approved by the legislature. And this didn't go down well with the presidency, and that makes the bill to be unsigned. So the good news is that the bill was represented this session, and I think as of about 2 months ago, it had a public hearing. And why not for this pandemic, it should have gone ahead to be signed into law. Notwithstanding the act, luckily for us, the National Health Act, I think was passed way back in 2008, has given a window of operation for national health insurance, especially where in the section 11, it allows 1% of the consolidated fund to be used for basic health care provision. And this money is supposed to be used in part to assist states in their health insurance activities. Well, before states can access this fund, there are some preconditions that they must meet. I think one of them is that each state will have put in place a state primary health agency. And then also, it will also put in place a state health insurance scheme, which must have been passed by the respective legislature of the states. The idea is to give these agencies independence and to insulate them from political vagaries. And I think as of today, about 18 states have made this condition so that they are ready to access these funds from the federal government. The third leg of the condition is that there should be an operational manual for disbursement of these funds. And that manual is supposed to be put in place by the Federal Minister of Health. Unfortunately, that manual has not seen the light of the day. A lot of arguments and complaints, particularly from the state, because at the last annual Council of States of Health meeting, which took place in Delta State, the states complained that the Federal Minister of Health have not given them enough information on how this manual will be put in place. I think by next week, there should be another meeting to resolve this. And the issue we have now is that, like I said, 18 states are already met the conditions to get this fund for their respective state health insurance policies. Beyond this funding, states also need a lot of support because they need policies. They need policies that will help their own schemes to thrive. They can learn from the experience of the national health insurance. They also need budgetary advice, because apart from the money from the 1% consolidated revenue from the which the National Health Act has provided, the states themselves also need to get money from their own budgets. And they also need to see how workers can pay into the system so that to make it very credible. Of course, people have been talking about the area of transparency. It's also important that we find a way to make the activities of the state insurance schemes to be transparent and corrupt-free. But let's be clear that the issue of corruption in healthcare system is a global problem. There's no country that does not have this. In fact, when I checked some records today, I saw that even in the US, the estimates given by the World Bank is that 3 to 10% of the healthcare fund in the US is lost to corruption. South Africa, about 15%. I'm sure people will say Nigeria will be more than that, but we have not got. But what I'm trying to say is that the issue of corruption, lack of transparency in the healthcare system is not limited to Nigeria, but we need to support the states. And I think, then again, there was a query by the Nigerian Medical Association a few months ago, trying to call out all their doctors not to cooperate with the states in the execution of their health insurance scheme. The excuse given by, well, the complaint by NMA is that the states are not taking the doctors into consideration in the execution of their scheme. I think that issue is still trying to be resolved. But having said that, we need to look out for some areas of possible corruption at the level of the states and in the execution of I'm not talking about the national now, because I think my own area is to talk about the state level. And some of the areas in the state is that we find people billing for services not given, not rendered. And also we find instances where people bill for services that are not covered. And then, of course, there is usually the problem of overuse of over-prescription. Sometimes, I mean, as a medical doctor who is also in practice, I know that sometimes doctors are under pressure from patients. Some of them will say, look, I have, in Nigeria, the family is family. They will say, even though the scheme allows me to take care of my family, 2 of my cousins have arrived from the village and they are sick. So you have to take care of them. I can't throw them out. You have to help me to accommodate them. Or some of them will say, well, I have an elderly woman at home, elderly mother at home. Can you please duplicate the prescription you have given me so I can give it to her to take care of? There are so many pressures on practitioners on this scheme. And these are areas where we need to see how we can support the states. Of course, some states have tried to fight their own corruption in their own way. For example, the introduction of the bank verification number, BVN, has in a way taken care of so many areas of corruption. Then we also know that many states have scrapped this multiple bank accounting system, whereby everybody is trying to do one unifying account, also trying to see whether they can cut off the corruption. Of course, we also have what we call the whistleblower mechanism. I know some states have adopted the federal government whistleblower. I know your state, for example, has also put in place a whistleblower system whereby there are some designated telephone numbers are given to the public, which they can call, and they can use that one to alert the government on issues of corruption. And of course, the budget allocation is another issue where we need to look at how corruption, because sometimes the amount of budget passed is not the amount of money that usually released. Some people will boast that my government is better than your government. At least I release 50%, and they think that's a big deal. Whereas a budgetary provision or a budget is a law, and you are supposed to do 100% release, not 50%. So many issues are also there where we need to look at. I know that the government cannot do all this, and that's why we have a lot of CSOs, civil society organizations, NGOs, which, for example, the NGO that is organizing this can also help in looking at this direction. Of course, we also need to say that even though the health insurance scheme in Nigeria, both at the national and state level, have been successful in the formal sector, how about the informal sector, where we have a lot of our people? I think we have more people in the formal sector than formal sector. And people will say, well, the reason why the informal sector is not coming into the system is lack of confidence. They believe that, well, even when we pay tax, what is it used for? But we have seen, and I think Lagos State has been used as an example, that if you have good leadership, good governance, and continuous transparency in the way you deal with your people, you see more people in the informal sector coming into the health insurance. And not only that, paying their taxes on time, because people believe that, well, apart from the money coming from the federal government, the money coming from the 1% consolidated revenue, the states also have to look for money from other sources, which I mentioned, their budgets, and also money from the workers. What the problem is, how do you get workers to contribute to the scheme? How do you get those in the informal sector to contribute to the scheme? These are the challenges that we need to look at. Overall, for me, just like we mentioned earlier, rather than bemoaning our fate, either because of the COVID-19 thing or corruption in Nigeria, I'm very optimistic that we can achieve a successful national and health insurance coverage, both at the national level and at the state level. I'll stop for now. Thank you.
Thank you very much. I hope you can hear me now.
Yeah, I can hear you.
Okay, thank you very much. Thank you very much, Dr. Okediran. Thank you for taking us through the process that is beginning to give shape to social insurance health schemes at the state level. So what we used to have was just a national program, but now we have a legal framework emerging. And you've also identified areas that we will need to work to assist states to take on this very early, so that it is not that it would have run for some time. I guess basically you're saying to those of us who are stakeholders here to start off by going to look at the law that is in the process and taking a cue from some of the things that you have said already. We can also begin to look at areas where there will be gaps. And in particular, you've identified budgetary allocation, and which is part of the work we've been doing for some time, budget monitoring, and ensuring that that works, and also ensuring that it's very inclusive in such a way that it integrates informal sector, people who are in the informal sector, who all too often are left out. Because it seems like we just tend to imagine that once it's informal sector, it's not our fault, it cannot be included, it cannot be integrated because it's informal sector. So for us, it's like defining the scope of our work for us in this area, that something is unfolding, but we must get on board early enough to be able to take that on. The next speaker is Comrade John Odah. And Comrade John Odah will be speaking to the issue of the political economy of health. And the aim is to assess the feasibility of a comprehensive and sustainable health insurance for Nigerians, the political economy of health, and to assess the feasibility of a comprehensive and sustainable health insurance for Nigerians. I believe that Comrade John Odah, coming from the labor sector, will definitely be speaking to us from that particular context. And again, it sounds like a very nice place to take off from, you know, as Dr. Okediran closes with a concern about who will fund this, the role of workers. And I think that just dovetails or provides an opportunity for what Comrade Odah would likely be speaking to us to just connect. So I invite Comrade John Odah to join us at this time. I hope that he can also try to be very succinct like Dr. Okediran was. Hello.
Thank you, Prof. A long time.
long time.
Let me apologize that I joined when the last veteran speaker spoke because I was having problem connecting, and also because I was just coming from another meeting. And let me say also the issues to raise because, okay, let me just say that my point of departure is that the state has a responsibility to provide for the healthcare of its citizens, and this cannot be compromised. It's one of the fundamental rights that any state, any person that seeks to be in government needs to do. And to the extent that successive governments in Nigeria have been failing in doing this, that's why we have such a crisis in the health sector, and that's why this pandemic has created an impossible situation that we have. This year's budget, has just over 200 billion allocated to the health sector, which is just 4.5% of the entire budget. And part of our crisis is that we go to international forums and agree on, without anybody forcing us on what we need to do. Way back in 2001, at a conference of the African Union held here in Abuja, it was agreed by all African heads of states that they should put a minimum of 15% of the annual budget on health. This, the Nigerian government has consistently implemented in the bleach. In 2014, following the Ebola crisis, the ECOWAS heads of states went to Accra and again re-echoed the need to have at least 14% of the budget devoted to healthcare. Now, I heard one of the speakers was making the point that the issue is not necessarily about the amount of money that is put on the healthcare, but that this is not being managed well, or that the private sector is not giving a leeway into this. One of the reasons why the healthcare in the United States of America is in such a chaotic state is because of the for-profit motivation, which the American governments and the pharmaceutical industries had put the healthcare system in. And even when Obama came and tried to give some form of universal healthcare to all Americans, you saw how this was fought, and up to now, the Trump government is doing everything to try to smash this. So from our standpoint, we have a whole lot of issues to address. The absence of the type of infrastructure which is required to sustain a universal healthcare delivery system in Nigeria. And it's precisely because enough money is not being voted. That is the reason why I think it was the Obasanjo government when he came during his second time that tried to award a contract for the building of healthcare facilities in each of the local governments. People can argue that this is not the responsibility of the federal states, that this should be done by the state governments. But to the extent that these state governments are not doing, the federation is equally owned by all Nigerians. So if the federal government, if we have a responsible federal government, it should be able to plan for healthcare to be available in the rural areas, in the grassroots. Now, since I know that I have a limited time, let's go to the efforts I think that have been made since the 1999, when there were a whole lot of efforts to move away from government providing healthcare for the workers. That means that before the second coming of Obasanjo, if you are employed in the state and federal civil services, when you go to the hospital, the government is supposed to pay. Or there is an allowance which is added to your wages for this. And when the government came with the healthcare, the National Health Insurance Scheme, this was one of the battles that the NLC then fought. And in terms of the funding, after, I think part of the compromise that we reached, which I think I remembered fairly well, was that the 10% of the workers' wages, which used to be paid for his medical care, should then be contributed to the National Health Insurance Scheme. I agree with the point that there's been a lot of problems there, because a number of the people go there in executive positions and hope to make money out of the scheme. But if the scheme is monitored well, this is one of the more sustainable ways in which a vast number of Nigerians can be provided with some healthcare delivery. But part of the problem that our health sector have had, and I suppose that the speakers before I joined must have alluded to this, is the fact that this country spends so much money in training doctors and other medical personnel like nurses, because of the way we've neglected to equip our healthcare, our hospitals and other health facilities. The type of brain drain that has gone to North America, Europe, and even other parts of Africa has been tremendous. And so we are then left with an inadequate number of personnel, despite the fact that we spent a lot of money to train these people. And the ones that are remaining are frustrated from doing their best as a result of the poor maintenance and facilitation in terms of providing the needed tools for work to be done. This pandemic met us under this type of situation where our healthcare system was on its knees. And even though the point had been made, in my opinion, wrongly, that this pandemic doesn't discriminate between the rich and the poor. But the facts of the matter, as we've seen, is that those in the informal sector and others who have to depend on the day-to-day work to be able to put food on the table are far more affected when they have to lock down, when they have to restrict, than the average middle class, not even to talk about the billionaires, who all they need to do is to just stockpile their food in their houses and wait for whatever period that the government decide that we should stay at home. So now that we have, trying to round up, now that we have this the people in position to make policy our political leaders need to realize that unless they fund our healthcare to such a sustainable level, in terms of pandemics like this, where they are prevented a bit momentarily from moving to other countries, they will have nowhere to go. But that secondly, and most importantly, where they are able to safeguard themselves only, by the time those who work for them, their drivers, their cooks, and others who stay within the communities, now have to come back to work. If they themselves have been able to have all the sanitizers, all the face masks, and all the made all the elaborate effort to protect themselves, by the time they come into contact with the other workers, with those who clean their houses and all of that, this pandemic can also get at them. So we need, in my opinion, to use this as a wake-up call to address the issue of adequate funding of our healthcare system. And I do not believe that this is something we should leave to the private sector, because the private sector is only interested in profit and not interested in the health of the people. Thank you, Prof. I think this is where I want to stop for now.
Thank you very much, Comrade Odah. Thank you so very much. Thank you for drawing our attention to the fact that we must think about these things in the disproportionate way, in terms of the disproportionate way that COVID-19 impacts, even if we think that it doesn't discriminate when it comes to infection. And thank you for giving us more details when it comes to the issue of budget, which the first speaker had in fact alluded to. One point that you had made, which I consider to be very significant and which must be flagged so that others can maybe think about it, is the fact that Nigeria spends quite a lot of money training health personnel. I know that, and at a pittance. At a time when medical students training to be medical doctors in Nigeria do not pay up to 100,000 naira in a session to train as, you find that they're living en masse, and usually it's the best of the best living, to go and serve countries where it costs not less than $200,000 to get a degree. So the average, a doctor is trained in Nigeria, heavily subsidized with less than $1,500 by the time he or she is graduating. At the most, it doesn't, in terms of cost to self, less than $2,000. And yet we do not seem to care. We're losing them in droves at all levels, whether they be nurses, laboratory technologists, and so on, or medical doctors or dental, the experts in the dental sector. But I think this is also something that we need to look at. And you did underscore the point that it is not just enough to train. It is also sufficient to provide an environment that people can work optimally and then they can feel fulfilled. Because many of the people who are leaving, it's not just about money. I know someone who said there's nothing as horrible as watching somebody you can help have to die because you do not have the equipment with which to help them. So thank you very, very much, Comrade John Odah. We move quickly to the next speaker, and that is Mr. Aminu Magashi Garba. Mr. Magashi Garba is going to be speaking to us on a holistic assessment of the Nigerian health sector in the context of the COVID-19 pandemic. So I invite Mr. Garba to please take the floor. I know he's here. He was here from the very start.
Yeah, thank you, moderator. I hope you can hear me well.
Yes, we can.
Okay, I will show my face after the discussion so that the network is not too strong.
Okay, okay.
Yeah, thank you. So within this maybe 10 minutes, because I know we don't have a lot of time, just to provide an overview of what we refer to the holistic assessment of the health sector response to COVID-19. It's a big ocean to really talk about, but I would like to take the simple ones that we'll be able to have a discussion and also interact with. Just to give us a summary, as of yesterday in the night, Nigeria totally, we have tested a total of 30,657 people for the COVID-19, 30,000 thereabout. And we have confirmed cases of 5,445, those who tested positive out of the 30,000. The active cases as of yesterday were 3,954, and the discharge were 1,320. Then we have mortality of 171 out of the total number of confirmed cases. What does this is telling us is we can even start our assessing the performance even from this information I just provided now. Nigeria with 200 million population, we only tested 30,657 people, 200 million population. Now, when you go to your neighboring country like Ghana, where the population is below 40 million, they have tested over 100,000, over 150,000 people. When you cross over to South Africa, to Kenya, to all countries that are far lower in population than Nigeria, they have, reached out to 150,000, 200,000 tests, and we just having 30,000. Now, this performance is actually under. We are underperforming in conducting tests. The significance of testing is that if we are not testing more, we are going to definitely forget many, and also those who are not tested, and if they are positive, they will keep spreading the infection, and they could also fall sick, and they will not be attended to. So that is the reason why testing is very paramount if we are going to, address the issue of the COVID-19 pandemic in Nigeria. So now the health sector in Nigeria, with respect to the response of the COVID-19, the highest group we have is the Presidential Task Force, popularly known as the PTF of today, not the PTF during the military. The PTF of today is the Presidential Task Force headed by the SGF, the Secretary to the Government, and it has a coordinator and the DG of the Nigeria Center for Disease Control and many other cabinet members. That is the highest body. What it does is it provides us with a regular briefing every day in the afternoon time to update Nigeria the progress so far in responding to the COVID. And also they try to coordinate the system, both the Ministry of Health, the state government, the Nigeria Center for Disease Control, and other personnel addressing the issue of the COVID-19. So one, a cursory overview, which we don't have much time, is that they are trying to engage with the Nigerians every day, which is quite commendable, and they respond to the media questions also on daily basis, and they try to coordinate also a multi-sectoral and also multi-stakeholder approach to the COVID-19 pandemic. One of the issues we kept raising with them, we in Abuja NGOs, is the fact that the entire Presidential Task Force is government. Everybody is a government employee. So this is, to me, one of the challenges of the task force. Everybody is a government employee. So what does that mean? It's difficult to promote accountability and transparency. It's difficult to engage and criticize as a member. You are a government appointee, you cannot criticize a PTF. We recommended that there should be a civil society rep in the PTF, there should be a media rep, there should be professional bodies and the labor union. Unfortunately, today, they have refused to listen, and they refuse to also respond to the yearnings of Nigerians. Then going down to the ladder, the biggest policy driving agenda is through the Nigeria Center for Disease Control. So, but we need to also correct some misconception. The NCDC is not doing everything. What it's doing is doing the testing, coordinating the testing, coordinating the surveillance, providing the policy guidelines and directions, and try to also coordinate a response. But the biggest chunk of the work is with the state governments and the FCT, where they have isolation centers, that if you are tested positive, you will be taken to isolation center. And also at the same time, you will receive treatment. And after some time, when you are tested twice, then you will be tested negative twice, you will be discharged. This is one of the area that the government also need to do more, because many a times, if you take away Lagos and a couple of states, the isolation centers are not well equipped to respond to the COVID-19. And also at the same time, the health workers, that is the workforce that is driving the agenda. There's a lot of, I'm sure all of you are aware that many health workers are being tested positive. Many health workers are dying because of the COVID-19 response. This is a calamity that we must stop. And how do we stop that? We need to ensure that the health workers providing the services are protected 100%. What we call the PPE, the personal protective equipment, that is the hand gloves, the face mask, the face shield, the gown, and the boot. Now, the challenges that we're having in the country in the performance is the fact that these PPE are inadequate in many isolation centers. And because of that, the health workers, they are even scared at times to attend to a COVID-19 patient or a suspected case. And because of that, we begin to see the rise of infection and also spread of infection, and so many people suffering because of that. This is an area of performance that we need to do more to ensure that the health workers are protected. And of course, also, all of you are aware that the allowance that they are supposed to be paid every month, the allowance of hazard is just 5,000 naira every month, you know, for a federal health worker or a medical doctor. In some states, there's even no allowance for hazard. Now, this is a big minus for a country like Nigeria, where we need to address the COVID-19. Something also needs to be done in that area. Then the services also, they need to be adequate. The NCDC need to be responding on time to calls. There are a lot of complaints by many people that when they call the number, and it takes a lot of time before they are attended to. And even if they are attended to, it takes a lot of time before the NCDC official come to their own houses to test them, and if they are positive, to take them to the isolation center. Another area that I want to summarize my session here is the fact that we should not forget that there is COVID-19 infection, and there are also other medical conditions. So this is also another big issue that we are also neglecting in assessing the performance. We have the COVID-19 infection, but there are many people with medical conditions, diabetes, hypertension, malaria, you know, cancer. There are so many medical conditions, and because of the COVID-19, the health workers, they are inadequate to address all the issue, and many of those chronic medical conditions, they are neglected. And even if you go to hospital, when you have those kind of conditions, because of the COVID-19 pressure to attend to it, those medical conditions are neglected. And most of the 171 deaths that I mentioned due to COVID-19, they are also comorbidities. You find that somebody died of COVID-19, but that person had diabetes or hypertensive or is cancer or on chemotherapy. So because those medical conditions are also neglected because of the COVID-19, that performance is also poor, and we need to do something about it. Now, to summarize and to give my recommendation, what are the opportunities? Some of the opportunity we need to look at, as the moderator asked us to also think about, is the fact that there's a lot of genuine interest, you know, within the health sector to support COVID-19 and to address medical conditions. I'm a health worker. I've seen a lot of appetite by health workers to be part of this process, but they are not supported with the personal protective equipment. They are not supported with allowances. They are not supported with a good enabling environment. If Nigerian government and the private sector and the business community could provide all these support to health workers, we'll begin to see a paradigm shift whereby we have a robust health sector, well motivated to support the Nigerian government to actually address the COVID-19. Thank you so much.
Thank you very much. Thank you very much, Dr. Garba, and let me just quickly apologize for not recognizing your well-earned title of doctor since I started introducing you. Please
That's
bear
no problem.
with me. Thank you very much. And so we quickly move on to the last speaker now, and this is Professor Gbenga Oduntan. Gbenga Oduntan will be speaking to us about financing, health financing, addressing the question of corruption and service delivery in post-COVID context. I was running through the charts to pull out the questions, and I found that about 3/5 of the conversation has zoomed around Dr. Banire's rather radical position that he thinks he can live with the lesser evil of corruption, provided he is certain that competence is not sacrificed. And there's been a lot of engagement. And when I looked again at the topic that Dr. Oduntan is supposed to speak to, I thought, well, we have the answer here. I wonder whether he can do it, addressing the question of corruption and service delivery. And that really is it, addressing the question of corruption and service delivery, health financing. So Dr. Oduntan, while I happily open the floor for you to, of course, the floor in space, to begin to speak to us on those issues. But I think that your topic really can help answer those, so that I think it'll be nice to draw some of these conversations from beyond which I think that there's no direction in which you go, that it will not address some of the issues that I say have been highlighted in about 3/5 of the charts that I have followed. Thank you very much, Dr. Oduntan. You have the floor.
Thank you very much, Prof Ayo Atsenuwa. Quite happy to be here today, and I have to start off by thanking the organizers of this webinar for making this opportunity available to us. It's a pleasure working with HEDA all the time. And I would like also to say that since I'm coming last, maybe I'll be able to soak up all the minutes that are left over. Who knows?
There are no minutes left over. Okay then.
There must be some benefits for coming last. Well, let's start off by saying that I should answer the topic of the day. And the topic of the day is whether Dr. Banire is correct in his assumptions about corruption and the fact that corruption does exist, but it's not our major problem. I will answer that along with my other, the things I will talk about. But perhaps I should just start off with a metaphor. What if you are told that in your garden at home, you have a dangerous spider, you have a cobra, and you have a puff adder, and someone is drawing your attention to the fact that it has something that can kill the two snakes? Would you say that until we're able to kill the spider, we wouldn't move on? Or we should kill the most dangerous of these three first? How do we identify the most dangerous? So I think what Dr. Banire is saying is that we should not only look at corruption, but I doubt he's really mounting a position in the favor of let's abandon corruption and let's just face the other one, which is incompetence. The two are mutually, we can do the two. It's not a case of either or, we can do the two. So I'll be talking about health financing in Nigeria, addressing the question of corruption and service delivery in post-COVID-19 context. Zooming through, I'd like to say the purpose of my talk is to contribute to a better understanding of what the so-called right to health is, and how corruption may attack this right or derogate from the soundness of the way we can express this right in practice. I'd also like to say that my talk should draw awareness to the fact that in the health sector, we need a bit more of law ethics, and transparency for our common good. I'd like to say that the anti-corruption awareness in the financing of health is something that is necessary and something which if we ignore, we are already paying for it. Needless to say that we are already paying for that on awareness that health issues and corruption issues, just like most other issues of governance and practical life, will go together. So that's the remit of my talk, and I hope coming out of it, I would have addressed the structural and facility level corruption that exists in our health sector, and would also have addressed the level of distrust that the citizenry have in the government and in their professionals in the health sector, nurses, doctors. It's a big shame. Here in England, where I am sitting right now, every Thursday at 8 p.m. in the evening, people come out of their homes and clap, just in their hundreds of thousands across the nation. They just clap into the emptiness of space, but knowing fully well the importance of that symbol to those who are in the health sector. That's because the social contract between the citizenry and the health sector has not broken down. And the reason why it may have broken down in Nigeria does include corruption, but it's not sufficient to say that it's only corruption that has caused it. What is health? Health is a state of complete physical, mental, and social well-being. That's what we are looking for. Health is not, and health issues are not only about people who are sick. It is the idea of maintaining human beings in a state of complete mental, social, and physical well-being. And it's not just the mere absence of a disease. So do we have a right to health? I would say yes. I'm an international lawyer. So when you are a carpenter, when you are a carpenter, yes, all problems will look like a nail. As an international lawyer, I've asked myself, do we have a right to health? And the answer is yes. There is a multiplicity of treaties, conventions, international law that maintain the idea that we do have, as citizens in our different countries, a right to demand health. That's complete physical, mental well-being I'm talking about from our governments. And I cite the WHO, World Health Organization Constitution. I'll draw attention to the International Covenant on Economic, Social, and Cultural Rights, Article 12, subparagraph 1. I draw attention to the Convention on the Rights of the Child. The Rights of the Child Convention is signed by all states in the world, because there's no state that doesn't believe in the future and in their children. The African Charter, again, on Human and People's Rights says in Article 16, every individual shall have the right to enjoy the best attainable state of physical and mental health. One of the papers that has come earlier raised the issue of whether should we rely on government, should we not rely on government. I'm not really ideological about that. But what I know is that as a human being, under international law, you have a right to good health, and your government obviously has a role to play in that. So what has Nigeria been doing about this right? Well, we have, in the last year, 2020, we have devoted 427 billion naira to health, the health sector. This is just about 4% of our annual budget. 4% for something as fundamental as human health. I think I don't need to say that's just woeful. We promised ourselves under the Abuja Declaration, which the African Union came up with, that we will spend 15% on health. We have not spent 15%, we are spending 4.5. And that 4.5 is even now being brought down by the fact that following the oil crash, the fall in the price of oil, we are now revising that 427 billion downwards. I think you can work it out. That's just going to show that it's going to be quite tough, not only this year, but in the future years. Because let's break this down. 427 billion naira is just $1.1 billion. 427 billion naira, $1.1 billion. And we are sharing this amongst a population of 180,000 people. So if you are sharing it with 180,000 people, I've done the maths. I'm a lawyer. My maths may be shaky, but I bet you, I think this one is correct. It boils down to 2,372 naira per Nigerian. 2,372 naira per Nigerian, which is just $6. In a whole year, we have only $6. I promise you, if you have traveled to Ibadan and you are coming home, you dare not show your face at home with something less than 3,000 naira, which will just be, what do you call it, the fried plantain and maybe 1 or 2 bread. You spend it on your way home. But that's all that our government has made available for us for health in a year. So therefore, as I have done, when I went to Igbobi, the orthopedic hospital, to see someone over the last few years, we find a situation where the toilets there are dirty. The toilets are, you have to pay to enter. And worse still, in the orthopedic ward, in a clinical setting, there is no pipe-borne water. They are actually using buckets to go and bring water to pour into big vats and then perform operations. When you pay peanuts, you get monkeys. So we're not spending enough on corruption. Sorry, we're not spending enough on health. And worse still, the little we are spending on health is being lost to corruption. Does Nigeria need any introduction on corruption? We don't. We already are at the latest Transparency Index figure shows that we are 146 out of 183, and we scored 26 over 100, 26%. Horrible. Why do we have this problem? A lot of it is because the money that should be spent in health facilities in the health sector is being siphoned away in what we call illicit financial flows. That's number one, the little we have put there. But how about the one we would have been able to spend if there was not a general corruption problem in society? I'll give an example about what I mean by illicit financial flows and what we have lost in what we could have had. Let's take the so-called Malabu Scandal. I'm sure a lot of us here would know the Malabu Scandal, where Shell International decided to have a dodgy deal with the former Attorney General of Nigeria and the former Minister for Petroleum, where they approved the Malabu, the most attractive oil well in the offshore of Nigeria, and gave it to Shell on an understanding that Shell will pay what was due to Nigeria, which was already compromised, which should have been about 3 or 4 times more, that they were going to pay it into the personal account of a company owned by our former petroleum minister, Dan Etete. That was $1.1 billion. They paid it into the personal account of a company that belonged to Dan Etete, who was going to now share it with a number of interesting figures in Nigeria. That 1.1 billion is exactly what I said we are spending this year on health. It went straight in just one deal. Of the 1,000 deals that go on in Nigerian governance, just one deal represents what we would have spent on our health for 1 year. And that's why we go to visit people in hospitals where they don't even have pipe-borne waters, in national institutions. So corruption is a problem. It's a huge problem. It's not something we can cover. We may have other problems, incompetence, poor education, but corruption should not be hidden, and we should not be ashamed to name it, and we should not be ashamed to address it either. So that's how I think we should look at corruption. But let's look to the future, and let's look comparatively. It's not just in Nigeria. In the US, The US president is a very interesting figure, but even just last week, he was talking about, 2 weeks ago, he was talking about his fears that the PPE, personal protective equipment, and a few other medications are being misappropriated by his own health sector. That's interesting. A former prime minister of Peru said something which I found interesting, and I will quote it. She said, "Corruption is embedded in health systems. Throughout my life as a researcher, public health worker, and Minister of Health of Peru, I have been able to see entrenched dishonesty and fraud. But despite being one of the most important barriers to implementing universal health coverage around the world, corruption is rarely openly discussed." Well, we are definitely openly discussing it here. These are the top 5 most prevalent corruption practices observed in Nigeria. Number 1, absenteeism. Doctors, nurses, physiotherapists, various health workers simply do not come to work. They don't come to work because they treat it as a second job, sometimes a third job. Sometimes they are not even the ones that are employed. Someone else is employed in their name. We have ghost workers. So absenteeism is one. Another one is diversion of patients to private facilities. Now, this is how corruption works. It's very difficult to pigeonhole every single act of corruption. They are all interlinked. Diversion of patients to private facilities is done deliberately because they will appear on the other side as well. Thirdly, inappropriate procurement. We know that. Contract deals, bringing your friends to show up for contracts and so on. Informal payments, theft of drugs, manipulation of data, so that when we are even trying to find out, as the last speaker has said, how many tests have we done? Who says that we have even really done 30,000? Can we believe that we've done 30,000, or it's just convenient to say we've done 30,000, whereas we've only done 15 because of the money we've actually thrown to the problem? So corruption even makes us doubt reality, and it's dangerous, because what that means is that when we start falsifying experimental data, governmental data, the diseases get worse. Microbial, antimicrobial, reinfection and problems creep in. Perversion of rules. These are all the areas in which corruption afflicts us in Nigeria as well as internationally. How do we know when corruption is taking place? And this is for the doctors, the CSO, those who are interested, journalists amongst us. When you want to know when corruption is afflicting an organization, there are a few things you need to look out for. And you can take a cue from the short list given by the Serious Fraud Office in the UK. It says, look out for abnormal cash payments. So once in a while, nothing stops our agencies, our ICPC, our EFCC, to find a way of checking the chief medical directors, the monies that go into their accounts and come out of it. And the money that goes into the accounts of their family members and goes out of it. Because, like I said, I have went to Bobi severally, Bobi Orthopedic National Hospital, and they don't have pipe-borne water. Somebody please prove me wrong on this. They go and fetch water from somewhere. Pipe-borne water does not get to the wards. And the toilets, you pay to use the toilets in the National Orthopedic Hospital, Bobi. How can that be? So someone must be using the money that's supposed to go into that. We can discover that through checking abnormal cash payments. Payments of money into shell companies, private companies, deals with contractors. Watch out for contractual engagements, procurement contracts. Watch out for lavish gifts between parties. Watch out for individual members of staff, doctors, administrators that don't go on leave. They are so hardworking that they don't go on leave. That's because something is coming in that particular spot he is occupying. That's why he can't afford to go on leave. Otherwise, someone else will come in and discover what's going on, or at least they will be losing out during that time. Individuals who decide to deal only with specific contractors all the time is also something else to watch out for. Illogical decisions, accepting projects, illogical decisions relating to projects and contracts, abuse of decision processes. So we must have ways of whistleblowing. We talked about that with HEDA in another conference just a few weeks ago. The whistleblowing should be encouraged in the health sector, particularly. So there are so many ways you can find missing documents, records, not keeping documents, records, bypassing normal tenders or contracting procedures. These are all ways in which you can discover corruption. In conclusion, because we don't have time, and I'm sure Prof will be very happy to hear that. In conclusion, we shouldn't hide from our problem. We have a perennial problem with corruption. We should address it. Competence does come into it as well. Because in addressing corruption, you have to address corruption itself competently. So if you have a bad competence record across the board, you won't be able to address corruption as well. That's where I will definitely agree with Prof. Because it seems in Nigeria, we think corruption is something that is only done by those in power and those in decision-making authorities. Corruption is with everyone. The policeman on the road, the gate man, everybody in Nigeria is in this. They are all into it, and then they are expecting it to disappear. So we must look at corruption. We must name and shame corruption amongst every one of us. The nurse you have to give a tip to treat your brother well when he's sick is involved in corruption. And they don't even see it as that in most of hospitals. They see it as gifts. No, it is corruption. We need to fight it everywhere we see it, not just with the governors, not just, they take away the large sums here, we know, but the culture that leads to that permissiveness is coming from all of us. So we need to look at it as a holistic problem and a multidisciplinary problem. That's why I'm quite happy with HEDA and the way they choose people for these seminars and conferences we have. Very multidisciplinary. We've had somebody from the labor movement. We've had someone from the medical sector. We've had people from law, academics. Multidisciplinary attack is one of the ways we can tame this huge problem that we have with corruption. Activists, scholars, regulators, EFCC, ICPC must recognize that the health sector is one of the areas they should look at. I'm doing a current study where we are looking at the Nigerians who have bought homes in Dubai. And it's quite interesting to see the sectors they belong to. From those sectors, you can tell the hot points of corruption in Nigeria. And I'm quite sorry to say that the health sector is one of it, particularly health insurance and some of the major hospitals in Lagos and in Nigeria generally. I don't want to get too specific at this stage, but the health sector is showing up on the radar of international illicit financial flows out of Nigeria. And therefore, it deserves the attention of everyone, ICPC, EFCC, activists, journalists, especially the various state ministries of health and, of course, the Federal Ministry of Health. We need to increase research into the health sector. We need to involve the health professionals themselves. We need to make sure that we measure corruption in the various stages, because without data, you can't do much. Without data, you can't even know how much you are hemorrhaging. Without data, you can't follow the trend of events. I just said that basically each Nigerian has 2,000 naira, round it up, 2,000 naira in the annual budget for his health. That should set us thinking. So when you have an accident, know that, yeah, the maximum service you can expect from Nigeria is just up to 2,000 naira, which is basically the amount for them to just open the gate for you to come in. After that, you're on your own, and you have to start spending some money on bribes. So we deserve a Nigeria without corruption. More importantly, we deserve a Nigeria without corruption in the health sector. Thank you very much.
Okay, networking. Sorry. Okay. Sorry, all the moderator, Prof, had little technical issue. She's coming back now, and I'm trying to get her back on board. I think it's been a challenge with internet connection at the most critical moment when she's to do the wrap up and then also welcome questions and answers from the participants. I would not make an attempt to put my leg near her shoes by trying to take over from the role of the moderation that she's handled very brilliantly. But then I will keep trying to see what we can do to get that back on board. In the absence of that, I know she's been taking note of some of the questions that were raised, both for some of the resource persons. But now I'm trying to go to the chat room and then see if we have, do we have any hand raised from the participants? Okay, no, okay, so no indication of any of the participants to raise questions, but she's going to come in and do the summary of presentation by Professor Oduntan. Okay, so I can see hands raised by Jude Nwabuzo, and then Dr. Abiola Akiode, and then Bayomi Akimbola. Can you do in 30 seconds? Jude Nwabuzo, please.
Hello.
Hello, yes, we can hear you, Jude.
Okay, I just want to raise my intervention in the area where Dr. Muiz Banire said about incompetency and the need for us to focus more on it. I think I quite agree with him, but I want to ask Dr. Banire how we can achieve, how does he think we can achieve that? Considering the fact that what we do presently today is like a vicious circle where you move from one political party to the other, and we seem to recycle same people within the system. How does it think we can go to achieve it by having the competent hand in governance in the country?
Thank you so much. Thank you. Dr. Abiola.
Thank you very much, Suraj, and the speakers. I think it's been quite interesting listening to everyone. I just have two quick questions. The first one is, it looks like two of the speakers were speaking around the rule of law, and they were telling us about what laws we have and what human rights can do in this regard. So my question is, in this lockdown period and this emergency period, what role do we think law can play to ensure that there is accountability around issues of health? COVID-19 came, but we already had this problem before COVID-19 came. So what role can law play in this regard to address the problem? Then the other one is, what opportunities can we see so that it's not all about us lamenting about the problem? So what opportunities can that help in terms of improving data on health? Or financing on health. So what can we do to mobilize actions around those issues to have a change in health system?
Okay, thank you very much. Professor Shehu Abdullahi.
Thank you very much. Thank you, Suraj. I would like to commend all the panelists for their excellent contributions. We need to move a little bit from the academics to the reality. and given my background, having experienced both sides of academic and practitioner, I would like to draw a slight consensus from what I have heard from the panelists regarding the first point that was raised by Dr. Banire about incompetence. It should be noted, as somebody pointed out in a note, that incompetence is a reflection of corruption. When you see incompetent people emerging as leaders or policy makers, is as a result of the fraudulent way of leadership selection. So, and from what Dr. Oduntan now explained, I think we have a consensus that to address our social security problems, we must go to the root of the problem. And the root of the problem is really corruption. Because when we talk of even the budget that some people are saying should be increased, it's not just the matter of increasing the budget. It what is done with the appropriated fund that is important. If you go to Ministry of Health, for example, if they are given 25 billion, you will find that 15 billion is spent on the other expenditures, not actually building the health infrastructures. So we need to focus fundamentally on addressing the problem of corruption in all sectors, and in particularly addressing our concerns with regard to social security. I thank you very much for your excellent contributions, and I hope this can be promoted, because this is by far the best group I have experienced so far in terms of virtual meeting in Nigeria, with over 60 participants, and yet the system is still stable. Congratulations. Thank you.
Thank you very much, Prof. Thank you so much. I can see that Professor Atsenuwa is back in the house. Prof? Hello, Prof.
Actually, I am only back without any visuals. I am back on the phone. And yeah, I'm only back on the phone. So I can't see anybody. I'm only looking at my keypad.
Which
but
is fine.
I don't know
what is most important is
I don't know what questions you have been able to take.
Okay, so the first question is asking about more insight from Dr. Banire on his allusion to incompetence as a major challenge over and above.
Okay, I hope he's had a chance.
Yeah, and the second one is looking at the role of law in in an emergency period like now, and what opportunities are inherent in this situation for mobilizing data, which was asked by Dr. Abiola Afolabi. I think that is actually generally to every other panelist, but the last one I mentioned was directed specifically to Dr. Banire.
Okay, have the speakers then been able to respond to those, or maybe they should just go ahead and respond to them?
Yeah, I have another hand raised, one Ibrahim Nuhu. So we can just take this one and one from Ezeilo, and then from there we can go back to the panelists. So Ibrahim Nuhu.
Okay, yes, Raj, good afternoon.
Afternoon.
Yes, discussion from the beginning to this point. What I want to contribute is that, I want to ask is that, I want to the presenters to say something about what we can do at the grassroots level, especially to track these palliative distributions, because like you see, I don't know whether some of you had the case that happened in Kano, where this palliatives distribution, one of the local government chairman tried to divert these goods that are meant for the poor at the grassroots level to his own personal consumption and uses.
Okay,
Give
thank you
to
very
us
much.
so that we can track it. Thank you.
Okay, all right. So we'll answer that. Ezeilo.
Yeah, thank you. First, the question I want to raise is, I don't know where exactly, but I think there was a medical doctor who spoke earlier, I can't collect his name, is about the health workers in the front line. How fair has the government been doing with them in terms of remuneration, payment, and fulfilling their promises to them so far? Then the second question I will also want to ask the doctor is also about the allegation of people being turned down at general hospitals or some other government facilities due to the fear of COVID-19. Is it part of the ethics for you to turn people down who have been sick, probably who do not have anything associated with COVID-19? Thank you.
Okay, thank you very much. Prof, I think you heard this one. Okay, yeah, I can see you're also trying to join through the computer. So I can hand over to you. Yes, I'm also trying to.
Well, yeah, so I am struggling to join. That hasn't come on, so I'm still speaking to a blank screen. But while doing that, I think we have the questions. We have a clear question.
Yeah.
That much of the chat has engaged the provocative statement by Dr. Muiz Banire, and I think that if he can just give us a quick, I think he's trying to clarify in the chat. And I think that really what he wanted to do was be provocative. But if he could just please expand a little bit so that nobody lives here under the mistaken impression or that we do not have a problem with corruption. So if he can just please clarify, that would be really helpful. But he should please be succinct.
Thank you very much, Prof. I think that, thank you for the opportunity, because I can see that there's a lot of misconception on the point that I struggle to make, let me put it that way. The point I'm making, let me first clarify in the first instance, I know corruption undoubtedly is evil. I condemn it, I believe we must fight it. That is not in doubt at all. But the point being made is that incompetence, we are not at all being worried about it. Nobody is addressing that. And my view, very strong view, is that they must go pari passu. In other words, we must equally start raising the issue of incompetence. There are policies that says, for example, federal character quota system and all that says put people in position because they are from a particular thing or because they must be represented, regardless of whether they merit it or otherwise. These people will put them in position. They do not, in the first instance, that policy that says so does not necessarily mean that the person now implementing is a corrupt person or the appointment is a product of corruption. No. What it means is that they are complying with the policies of state. But at the end of the day, what this throws up is that we end up having somebody that is incompetent. You now put that incompetent person in that office. The person does not know his right from toe. At the end of the day, the entire expenditure, the entire fund that allocated for the purpose of realizing your objective will just be wasted because the man does not know how to apply it. Now, take a corrupt person, an incompetent person. Once it goes that direction, you lose the entire thing. A corrupt person might still deliver some measure of things for you or services, but at the end of the day, still part of the money. But the other man entirely will make sure that at the end of the day, nothing even comes out. And the point I'm therefore making is that we need to start addressing the issue of incompetence alongside that of corruption. Over the years, decades now, we have all been talking about corruption, not even paying any attention to the issue of incompetence. My submission, therefore, is that alongside the issue of corruption, we must start raising the issue of incompetence, putting the right person in the right position. So that at the end of the day, this is in my own very strong view, the only way we can achieve our purpose, fighting corruption, fighting incompetence. Those two must go together at all point in time. And that is a point I've been making. And I'm glad that the last speaker, discusser, equally made that point clearly. That look, we must start, he gave a good example and a narrative and said, even the person that must fight corruption must be competent. If the person that you have chosen to go and fight corruption is not competent, at the end of the day, you defeat the essence of the struggle or combat. And that is the point that I'm making, and people should not have that misconception. But I even said, in addition, that from my own experience in public service, what I've seen that incompetent people, they do more harm to the system than even these corrupt people. My experience, And I have, like I said, somebody said I mentioned some names of some people that have performed well without, that are competent, but I won't do so in the gallery, but I can engage anybody and give name. I've given a state example like Lagos. Whoever can guess well can guess correctly, that we have some people that have performed wonderfully because they are competent, but it does not say that they are not corrupt, because some of us know, and some people also know. But the truth is that they deliver to a large extent. So in conclusion, moderator, my point is that why not relegating corruption to the background? Let us start making the issue of incompetence a conversation equally. That is the point I've been struggling since to make. Thank you.
Thank you very much. Thank you very much for that clarification. I would ask Larry that you please be co-chair with me, because when some of the questions were coming, I was on really, it's a bit difficult for me to direct the questions to the speakers. So I will ask you to please deal with that. And if I think that there are any questions I have pulled out earlier on, which have not been, I will come back to them. It would appear that there is a question for the first speaker, Professor Ezeilo.
Yeah, I think that for Professor Ezeilo would be about the role of law in the emergency period and what opportunities are there for mobilizing data. Hello? Is Professor Ezeilo still in the house?
Yes, I am.
Okay.
Yeah, okay, thanks so much. I think as you know, it's been a long while coming. We're moving from the courtroom to the courtyard and everything.
Yeah.
I think some questions have come up, and I just want to reinforce or reiterate the fact that the international instruments, and we have quite a number that are relevant here, including the Sustainable Development Goals, that speak to issue of social security, that deals with the issue of social services and bridging the digital divide, whether in terms of infrastructure, urban, rural infrastructure, and access to that, including affordability. We have to also remember that apart from provision of adequate health services, there is an obligation to provide information, education, and communication programs to all, especially women and the poor in rural areas. So for someone, I think there was a question about what can people do at the level of at the in rural areas to bring awareness to this. Of course, we know that the government is, we stand a little chance actually in terms of even overhauling our healthcare or trying to have a good social security, especially in with the economic situation in Nigeria and some of the poor developing countries. We cannot do it without external, not only external funding, but also borrowing. And this is where when we borrow, what happens if we borrow and you don't track the money and it's not used properly. You can see just recently some Abacha loot were returned from the US during this COVID period, and they put a lot of caveats, and they have a committee made up of United States experts and Nigerian that the fund will be used for ABC spelled out, and there's going to be continuing monitoring of the process. And this is again where civil society comes in. And I did make this point very clear in my presentation about actions that we need to be taken, including raising the accountability stake, being able to monitor even when we have health financing, whether private, public health financing, which looks like the way to go. Public partnership for health financing and bringing others investors in that area, because obviously the government can't go it alone, even if they were not as corrupt as we have, and the cost of governance is not what it is. So we have to also look at the nutritional services in this COVID era. It becomes very important. Postnatal care, and I've had the question about what happened. People are being turned away from other health facilities because of COVID cases or anticipation that they're overwhelmed and they don't want to admit other cases. And some other people can't even access some facilities or some kind of healthcare they require. Like if someone is a cancer patient and need to go for chemotherapy, there are very few facilities for that. They may need to travel from maybe Enugu to Abuja or somewhere, Benue to Ibadan, things like that. And then how do they do that? They can't do that, obviously. So the government have to begin to take their responsibilities seriously. They have to ensure appropriate prenatal, postnatal health care and develop preventive health care, because this is a time to begin to talk about that. How do we, people hailed us that we dealt with Ebola, but we didn't know it was just a child's play, because then there wasn't really, and the transmission didn't happen the way this one is happening. And it wasn't something that was a pandemic all over the world, the way WHO has declared this. So for countries in Africa and in Nigeria in particular, the significance of these treaties stem from their potential to have transformative impact on the health and well-being of citizenry, the quality of care, goods and services, and what they are able to access. Because we're talking of palliative, even people, we heard about the quality of some palliative shared, and people throwing it into lagoon. And then, and it tells us something about even this issue of quality control. So when we talk of social services or access, it doesn't mean that you dump people or give people what is bad. It has to be also something that meets a certain standard. So the problem, that is that we stand little chance of attaining even the targets set in the Sustainable Development Goals. And the health budget, national health budget, is a time to have national strategic initiatives that will be supplemented with external resources, because it's only through those with those support that we can begin to scratch the problem, which is elephant at this stage. Yes, corruption has something to do. Corruption is a human right because it undermines people's right to development. It undermines people's right to life, including right to attain highest attainable standard of health, treatment, prevention, control of epidemic like we have. And it also undermines the services that people are supposed to get, including social insurance. So we cannot diminish that. We cannot diminish that. And it's the corruption itself that engender incompetence, because also you can look at it as a cause and a consequence of incompetence. Because corruption has eaten deep into the fabric and is hydra-headed monster, corruption is not just taking embezzlement of money at the white-collar crimes we know, but also when people begin to compromise standards because it favors their own ethnic group or religious or whatever, then is already you're promoting incompetence and merit, and you have subjected anything that there is no longer objective tests, and you're using all kinds of subjective tests. That's not to say. So it's both a cause and a consequence of that competence that we're talking about. So I think I've taken basically all the questions that were thrown my way.
Thank you, Prof.
When I fail to answer, please just draw my attention to it.
Thank you so much, Prof. Okay, all right. I wanted to read the next one, which is talking about, and I think this will go to Dr. Magashi. And this is talking about how fair is the remuneration for from government to frontline workers, and also the rejection of payments by some of the hospitals.
Please, can you repeat the question?
It's asking about the remuneration that government is paying to frontline workers. How consistent, how constant, and then how transparent is the process? And also the complaints about several other patients who are turned away at general hospitals and other places for the fear of the COVID-19.
Yes, thank you. This is very important questions, and I hope HEDA, beyond the webinar, should move forward to begin to collaborate with health NGOs to find some solution. So generally, the health workers have allowance, what we call hazard, every month, and it's 5,000. So for medical doctors, and the formula varies with nurses and other health workers. So, but this is general for everybody. But with the COVID-19, what we are recommending to the minister and all the commissioners is that the COVID-19 has exposed health workers to more hazard. And because of that, there should be more better allowance than just collecting 5,000 every month. There should be either a weekly allowance to take care of communication, feeding, and some also hazard as they face their own work. With respect to the question you asked about patients being rejected in public center, that is true. We have to find a solution to that. And some of the reason is the doctors and the nurses, they don't have enough personal protective equipment. For any suspected COVID-19 case, the doctor or the nurse, they have to be kitted very well with the gloves, the gown, the face shield, the face mask, and the boots. Many times, those equipment that we take for granted, they are not available in facilities, or they are just few of them. Yesterday, I was at one of the federal medical centers in Abuja, and I saw how nurses are struggling to get this, personal protective equipment. So yes, true, some patients are turned down, but we need to also understand the risks that the health workers are also facing. We have lost so many doctors and nurses due to COVID-19, and many are infected. In one of the tertiary centers, about 15 of health workers in one day were tested positive. That means all of them are going to go into isolation or quarantine for 2 weeks. Who is going to cater for the patient if 15 health workers are away due to the COVID-19 infection? These are, a very serious issue that I hope that beyond this webinar, we need to really explore how we can engage in advocacy to the federal government on that. Thank you.
Thank you very much. I think the last one is talking about how to monitor the palliative at the grassroots, and the Kano experience was referenced. Maybe we can talk to Comrade John Odah on that. Hello, Comrade. Hello, Comrade. Okay. I can see him online, but is muted.
Yeah.
Okay, good.
Yep.
You're online, sir.
Okay.
Yes, over to you. Hello, Comrade. Yeah.
He's muted.
Yeah, I'm trying to unmute him. I think something is off somewhere.
Well, maybe we come back to him and
yeah, I possibly need to unmute from his end. Yeah, I think that's actually the last question from my end.
Okay.
So I can hand over to you.
I think thank you very much. So I finally managed to get back on just before the end of the meeting. I want to say that I think that we have had a very rich and engaging discussion. The agenda has been set for us variously. Some provocative questions or issues have been raised. And basically, what we have to do is actually get back to work. Between when I was struggling, I think I had somebody say, or maybe I read it in the chat, that we really must move away from the postulations. We really must move away from the jaw. We just must back up what it is that we are talking with a lot of action. Action has been taken to date, so that's not to suggest that we haven't done anything. And someone's talked about the case that's been brought against somebody in Kano State who diverted palliatives. So some great work is already going on, but I see that a lot more work still needs to be done. And some of I know this meeting is being recorded, so the notes will be taken and the strong recommendations will be pulled out. But some of the key issues that I see addressed include budgeting, ensuring that we have not just adequate budgeting, but I wonder when Comrade John Odah made a reference to 40%, I really wonder whether we can just take the whole of 40% and put straight into health. But I suppose we can achieve as much as 40% when we understand, as has been stated clearly in this meeting, that what we do about health education, which may come under education, what we do about strengthening technology, because I saw that in one of the chats, ensuring that technology, IT is available, accessible, even in the villages, the way it will go on to enhance health. We've talked about environment, waste disposal. On the face of it, it might not look like allocation directly to health, but it becomes allocation to health. Dr. Banire has emphasized the issue of competence, which is talking about the quality of education. Because I would imagine that many of the people that we even say are not competent in Nigeria are usually able to provide some certification, some academic certification, indicating that they are competent, but the competence that's expected to match the certification is what there is a problem with also. So we see that it looks like we really can't afford to do business as we have been doing business. And it is time for us to really get back to the drawing board. Now is the time that the state health insurance agencies are being put together. We've been told what we must do. So it looks like the agenda is being set already. And I am charging us as HEDA to not only just produce a report out of this, but produce also actionable interventions or areas of interventions that different groups of people can actually work with, whether they're at this meeting or they're not at this meeting, when they get the opportunity to read the report that will be the outcome of this. And on this note, I think it's imperative that we bring this meeting to an end around now. In terms of scheduling, we would have been at it for about 3 hours. Some people were here before 1 p.m. And I think rounding up around now is just going to be the right thing to do. I want to thank everybody who's made this a very, very vibrant dialogue. I want to thank you for bringing to bear, particularly our guest speakers, who, you putting yourself out, taking this assignment very seriously, and really, really, really defining the issues for the dialogue. I want to thank the participants, because without participants, there would be no meeting. And I want to say that for those participants who have been here, who have listened, who have chatted, who have raised questions, without you, we really would not be able to have, we won't say that we have been successful at having a meeting, a dialogue. So I want to say a very, very big thank you to you all. This is only one of the many things that are taking place side by side. I hope that we will be able to pull all this together, and in time, we will begin to see the outcome of the time devoted to these dialogues and many others. Thank you very much to all our speakers. Thank you, thank you, thank you so much. And at this point, I will just hand over to Larry Suraj to do the
Thank you very much. Thank you very much, Madam Moderator, for the professorial moderation of the forum. We really can't thank you enough for the inspiration and the support. I can remember that you're one of the first set of people that started nudging us to say, you guys, what are you doing about this? How do we engage the process without having to wait till the end? And one of the key points that you made, which was of a very great motivation to us, was the fact that we can't afford to continue lamenting and then only counting the losses at the end of the process, but rather it should be that we engage the process to ensure that we get, service delivery for the people, and then hold them, the public officers, accountable in the process of implementing the design program. So we thank you very much, not only for today, but for before now. And I can assure Dr. Magashi that we would, at the end of this session, so we would open a conversation with him to continue with the process on engaging with the health care workers to see how things have been done, the ones that are done appropriately. We've received quite a lot of complaints, especially even from Abuja, on how frontline workers are being shortchanged and how they are being maltreated and the rest of that. We know this to be the practice with public office holders. In the midst of the pandemic and the crisis of the ordinary people, there are quite a lot of people in the public office who are waiting to profit from the misery of the ordinary citizens. And these are things that we really want to make sure that we put an end to that as much as we can also thrive at our different levels. In terms of tracking, I want to just respond to the CITAD participants from Kano, that we actually started the monitoring process. And interestingly, Kano is one of the 10 states where HEDA is collaborating with other civil society organizations and the media to track the process. And we should be coming out with a report, hopefully in a couple of days, because we've concluded the physical survey and monitoring process. On the last one, hopefully, and we're almost closing on that deal, we would bring the chairman of the ICPC to also be at the ACSR virtual platform, because the ICPC already came forward with a guideline for the utilization of the COVID-19 fund. And it will be important for civil society and the media to engage that process. The anti-corruption agencies are not, spirits, and it takes, the collaboration of other citizens, the civil society and the media, to make their work effective and efficient. And that is what we want to do by bringing possibly himself and the Accountant General of the Federation, who has actually also issued a guideline. And that guideline was very instructive to the extent that every MDA must respond to the FOI request from the media or the civil society or even ordinary citizens. And any attempt not to do that is an indication of corruption. So we must give life to that guideline by engaging that process. And hopefully and ultimately, at the end of this, we should have public hearings where people can speak of their experiences, to government and to other stakeholders. On this note, I would want to once again, like Madam Chair and Moderator already did, appreciate everybody for your contribution and participation. And we look forward to further engagement on very topical and relevant issues in the area of accountability, transparency, and good governance. On behalf of HEDA and my colleagues at the background doing the technical work before now and today, we appreciate and thank you very much for being part of the process. Thank you very much. Bye to everyone.
Thank you very much, everyone.
Bye.
Thank you so very much for making it a fun afternoon, yet great intellectual.
Okay, thank you. I'll sign off. Thank you so much.
Thank you.
Thank you.